Thank you for the opportunity to speak today. It's been a little while since I've been back to Kittitas, so it's nice to be back. And I get to talk to you about acute stroke. And why should you care about acute stroke? What is all this about? It's the fourth leading cause of death behind heart disease, cancer, and chronic lung disease. The number one cause of long-term adult disability. There are almost 800,000 strokes every year in the United States. So a stroke occurs approximately every 40 seconds. Over 80% are ischemic, so most of the talk today will focus on ischemic stroke. About 8 to 13% are hemorrhagic, and then the remainder are subarachnoid hemorrhage, usually caused by aneurysm. So for the focus of the talk today, we'll spend a lot of time talking about TPA, looking at the data, the risks, and the benefits, and then talking a little bit about mechanical interventions. We'll focus on secondary prevention for ischemic stroke, which follows up on some of what Alex covered as well. And then just a little bit of time at the end for care of patients with intraparenchymal hemorrhage. So the modified Rankin scale, I just wanted to cover that because a lot of the studies refer to modified Rankin scale scores. So as you can see here, the score ranges from 0 to 6, 0 being no symptoms at all, and 6 being death. And I just wanted to highlight, because of a lot of the studies talk about modified Rankin scores of 1 or 2. So 1 is no significant disability despite symptoms, able to carry out all usual activities and duties of living. 2 is a slight disability, unable to carry out all previous activities, but still basically independent. The patient doesn't need assistance. So here's our first case. 64-year-old male with a history of hypertension, hyperlipidemia, and diabetes. He also has obstructive sleep apnea and smoking. He has sudden onset of right-sided weakness while at work on his smoke break at 11:30 a.m. He arrives in the emergency department at 11:48. So this is one of those patients that gets in very quickly, and it seems like you all have more of those patients here in Ellensburg than even we do in Seattle. It seems to take our patients much longer to get in. So it might be a typical kind of scenario for your patients. He has right facial droop, right arm and leg weakness, slurred speech, and mild sensory loss on the right side as well. So what do you think? Does this look like a stroke? Yes. He has acute onset of right-sided weakness without aphasia. So what are we thinking about possible location of the stroke or type of stroke? Any thoughts?
Left side.
Okay, yes, good. And it's suspicious for a lacunar stroke with the mixed motor sensory deficit, no difficulty with aphasia. And so it's important that we, of course, address ABCs, clarify his history, looking for any contraindications that may be there, otherwise we're proceeding with TPA. And then also confirming the exact time that he was last seen normal or last seen well. So in this case, it does check out. So it's like I showed you on the previous slide. So what would be our next steps for this patient?
Blood sugar?
Yes, blood sugar is good. And because we're thinking stroke, our stroke alert. And getting ready for IV TPA, mobilizing, moving forward. So we obtain a head CT without contrast, the glucose finger stick, thank you, Linda, blood pressure, other labs, platelets, hemoglobin, sodium, we're looking at coagulation, EKG, and possibly a chest x-ray, but we wouldn't want to hold up TPA to obtain those tests. And then scoring his NIH stroke scale. So why do we give TPA? This is a meta-analysis published in Lancet in 2012. Most of the data was from trials done in Europe and included over 7,000 patients looking at TPA given in less than 6 hours for patients over the age of 18. And the results showed that TPA given within 6 hours of stroke significantly increased the odds of the MRS of 0 to 2, so that's that alive or independent at the final follow-up. But the benefit was greatest for those treated in less than 3 hours. And you can see those results here. Interesting to note that they saw the same benefit in that time window of less than 3 hours for patients who were over 80. And why wouldn't we give TPA? There's the increased risk of symptomatic hemorrhage. However, death at 7 days was less of a risk. And we definitely see less risk and the most benefit when it's given in that 3-hour time window. Some benefit when it's given up to 4.5 hours. But who doesn't benefit between that 3 and 4.5 hour window? Tends to be patients who are over the age of 80, patients who have a history of diabetes and prior stroke, patients who are on anticoagulation. So those are part of that additional exclusion criteria that we look at for patients who are in that 3 to 4.5 hour time window. And why don't they benefit? There's partially the increased risk of intracerebral hemorrhage, but also their outcomes weren't as good. This is a helpful kind of image that we can share with patients and family to convey the benefit versus the risks of TPA for acute stroke. And this is especially helpful for those of us who are visual learners. And so if you see here, if you had 100 patients who were given IV TPA, you see a majority here are just kind of outlined figures there in the white. Those are patients that had no major change after TPA. Up here you see the dark green patients, and those are patients who are normal or nearly normal after TPA. The lighter green were patients who were better. And then down here you can see there's the 2 patients who are red. Those patients were worse. And then the 1 patient that's that darker red was severely disabled or dead, so 1 patient out of the 100. You can also see there's these 3 other patients that have the little minus sign there. Those patients had early worsening with brain bleeding, but overall there was no major change. So this is something we use in the emergency department. We keep it as part of our tools for TPA, that we have that available to show that to patients and family. This was a registry that tracked bleeding and outcomes after TPA, and it showed that, so their definition of symptomatic ICH were patients that had a bleed, mass effect, combined with an NIH stroke scale worsening of 4 points or more, or death. And they found a rate of 1.7% symptomatic ICH. And when you compared their outcomes with other previous trials, there was really no major change in outcomes once you take into account age, NIH stroke scale, or comorbidities for the patient. This is a great image to show that the importance of time. And this is a pooled analysis to look at the relation of stroke onset to treatment time. So that's what's down here on the x-axis, onset to treatment time, with favorable outcomes at 3 months. And this was a modified Rankin score of 0 to 1. And you can see here that over time, that chance of that good outcome declines. And so the sooner you give TPA, the better outcomes for the patient. This time here starts at 60 minutes. So what if we were giving TPA sooner than 60 minutes? And there is a trial right now in Germany called the Phantom trial. And they're actually using ambulances equipped with a CT scanner in the ambulance rig itself, and scanning patients immediately and starting TPA before hospital transport. So the early data has been good, looking at safety and no increased risk of bleeding associated with that earlier TPA administration. But it'll be interesting to see what that data shows in that prior to the 60-minute time frame. So what is the criteria for giving IV TPA? Blood pressure must be less than 185 over 110. This is the only reversible criteria. Platelets greater than 100. The INR must be less than 1.7 and a PT less than 15. If the patient's on any of the newer anticoagulants, they should not have had any doses within the past 2 days, and they need to have normal coagulation times. And if on heparin, they need a normal PTT. Age greater than 18. And as we mentioned before, can be given in less than 3 hours or up to 4.5 hours in a selected population. The other exclusion criteria: a recent arterial puncture at a non-compressible site, significant head trauma or stroke in the last 3 months, symptoms of subarachnoid hemorrhage, history of previous ICH, or intracranial neoplasm, arteriovenous malformation, or aneurysm, or recent neurosurgery of the head or spine. And I wanted to mention that this is all part of the discussion that you're having with neurology when you make that phone call. Because, for example, stroke in the last 3 months, if that's a small lacunar infarct, it's likely okay to still proceed and give TPA, but it's part of that discussion. These aren't absolute contraindications. And also a CT with multilobar infarct, larger infarct, also a contraindication. Other relative exclusion criteria: MI in the last 3 months, recent major surgery or trauma, recent GI or GU bleed, pregnancy, or a minor stroke or rapidly improving symptoms. And similar to what Dr. Takash was saying, that gets hard to identify. What do you call a minor stroke? And so I think the best way to identify what would be a minor stroke is to think if the patient were going to have, if those deficits did not improve, would that be disabling in any way? Would that affect their activities of daily living or their life in any way? So if they had minor numbness of one hand, but it didn't affect the function of that hand, then yes, we could maybe say that's a minor stroke. And then it's also important to note that the patients that have what's classified as a minor stroke have a lower risk of bleeding with TPA. So back to our case. His head CT is normal. Here's his lab results. His initial NIH stroke scale is 9. He is a good candidate for TPA, but he needs it right away. Less than 1 hour out and 32,000 neurons per second are dying. So we have to move forward very quickly. And you've probably heard the benchmark for door to TPA time is 60 minutes. And certainly the sooner we can give that, the better chances we have for better outcomes. So this patient receives IV TPA and is admitted to the ICU. We will not start any lines or arterial punctures for 24 hours. No aspirin or other antiplatelets or anticoagulants for 24 hours. And that would be started only after repeat imaging at 24 hours is negative for bleed. And keeping our patient NPO until the bedside swallow evaluation to decrease the risk of aspiration pneumonia. Blood pressure goals post-TPA, less than 180 over 105. And we want to maintain normal glycemia, normothermia, eunatremic and euvolemic states. If the patient did not receive TPA, the care would be quite similar, except our blood pressure goal would be more liberal, and we would allow the blood pressure to run up to 220 over 110, and we would start aspirin sooner. So here's the MRI on our patient. It's a little bit hard to see in here with the bright lights, but you can see this area here, a little bit large for a lacunar infarct, but left internal capsule, which fits well with the patient's right-sided weakness and slight sensory loss. So for this patient, therapies were started the very next day. He was discharged to rehab 6 days later with continued weakness. And he followed up in the stroke clinic 3 months later with mild residual weakness. Additional thrombotic workup, fasting lipid profile, and hemoglobin A1C for patients with diabetes or if they have an abnormal fasting blood glucose. EKG initially, and then telemetry is recommended for 24 to 48 hours to rule out arrhythmia. We could consider a transthoracic echocardiogram to rule out any cardioembolic source. And we could consider intracranial vessel imaging. So up here we have the carotid ultrasound. And so just like Dr. Takash was talking about, it's considering which vessel imaging you're going to get. And most of our patients were getting the CTA. And then the other option is the MRA. And with those, you can look at the intracranial vessels as well as just the neck vessels. So what if it wasn't a stroke? Common mimics of stroke, migraines, conversion disorder, seizures, and others. And this was an interesting study that looked at patients with stroke mimics, and this was a retrospective review over 4 years. And there were 519 patients overall that got TPA in the study. 106 of them had no evidence of stroke on their MRI. So 69 were stroke mimics. And this is the breakdown that they found. This study was in Texas. And the most common etiology of stroke mimic was seizure, followed by migraine, and then third was conversion disorder, and then the other etiologies are listed here. In that study, the hemorrhage rate for patients with stroke was 5.8%. What do you think it was for the patients with a mimic that received TPA? What do you think that hemorrhagic rate was? Any guesses?
Lower.
Lower indeed. It was actually 0%, even though there was a 14% mimic rate. So I think this is reassuring because we're often pressed with time, right, to give TPA, and it's not always easy to figure out the exact diagnosis in those early moments. Another case, 66-year-old gentleman with sudden onset of left-sided weakness of the face, arm, and leg. He had a left visual field cut, a right gaze preference, slurred speech, and left-sided sensory loss. His eyes were deviated to the right, and his head was deviated to the right as well. He got TPA, but his NIH stroke scale was 19. So further imaging is indicated. And you can see here on the CT angiogram of the head and neck, this is the coronal slice, so looking down this way, you can see the absence of blood flow there on the right. And then as we look at a 4-vessel cerebral angiogram, the AP view, you can see here that there's this area where the contrast is just a string of contrast there in the carotid. And then also here you can see this sort of stump there where the blood flow stops, and we should see blood flow beyond that point. So one of the mechanical devices that we are using at Virginia Mason is called the Solitaire. And this is a video to show you a very similar device. It's a stent retriever, they call it, or a stent on a stick. But I'll just show the video. Doesn't matter if there's sound or not. I can talk through it either way.
Just what is an acute ischemic stroke, and how does it happen? Clots can form in the heart or in the arteries due to various causes. A clot formed elsewhere is called a thrombus, and it can break loose and begin traveling down the artery with blood flow. Now it is called an embolus. Sometimes the blood flow will lead it to the brain, where it can block one of the arteries that is supplying the brain with blood. When this occurs, it's called an acute ischemic stroke. To clear the blockage and restore blood flow to the brain, the physician may use a clot retrieval device, such as the new Trevo Pro, the first device developed exclusively for maximizing clot integration and efficient retrieval. Using a balloon guide catheter and with the aid of a suitable guide wire, the microcatheter is advanced through the occlusion and positioned distal to the clot for accurate deployment. The guide wire is then removed, and with the aid of fluoroscopic imaging, the Trevo Pro retriever is carefully advanced up through the microcatheter. After positioning and unsheathing the Trevo Pro retriever, allow time for maximum clot integration. With its vertical strut orientation and tailored radial strength, the Trevo Pro retriever is engineered specifically for efficient clot integration. In addition, Trevo Pro's tubular stentriever design and spiral cell alignment conform to the vessel with uniform cell area and no cell overlap. Enhanced conformability promotes excellent clot integration regardless of tortuosity. Prior to retraction, the balloon guide catheter is inflated to occlude flow. The Trevo Pro retriever and microcatheter are then pulled down as a unit while slowly aspirating through the balloon guide catheter. Vigorous aspiration is started through the balloon guide catheter as the Trevo Pro retriever and microcatheter are removed and full revascularization is verified. In treating a stroke and restoring blood flow to the brain, time is critical. Trevo Pro is the one system designed to integrate across various clot types.
As soon as that stent is deployed, it's restoring blood flow to the area immediately. And so that is very beneficial for patient outcomes. The stent is left in place for a short while, and then when it's retracted, the clot adheres to it and brings the clot out with it. And so we've seen some pretty amazing, and I don't have any of those Dr. Robinson images, but he's got some showing the stent with the clot adhering to it, and it's pretty impressive what you can see.
So how long are you leaving that before you pull it back?
5 minutes.
Do you want to repeat that question?
Oh yeah, sorry, how long do you leave it in place? And the answer is 5 minutes. Thank you. Yes. So for the same patient that we talked about that's got this stump here or occlusion, there's our after the solitaire, and here was that previous previous occlusion, and now you've got blood flow beyond that. And here's the patient's follow-up MRI, which you can see the infarct here, but that's actually pretty good considering the territory that was at risk with that occlusion. So let's hear how our patient did. 3 days later, he was ready for rehab, walking with assistance with mild left-sided weakness. 3 months later, he is independent with all of his activities of daily living and has very mild left-sided weakness. It's a very good outcome.
So on that case, what would the MRI look down the road?
That will look very similar to that.
So it doesn't change much, even though
It doesn't.
function-wise he's improved.
Right, so the DWI basically is not very reversible, with the caveat that we don't know in the first hour. So I have had a few patients that, for a variety of reasons, did get an MRI before they went to intervention. The timing was unclear, but in retrospect, the timing became more clear. We could actually quantify that. And we've seen massive reversal of DWI, but it has to be reperfusion in less than an hour, sort of people.
Okay.
And that other people have found that too, but it's all it's just cases right now, so we don't know.
And I think with the cardiac, TPA initially and now stenting.
Yeah.
Yeah,
the heart muscles
you
are
can
so
see
much
that
more resilient.
Yeah, it's a little bit more resilient, isn't it?
Yeah, way more resilient.
Yeah.
Yeah.
What's the time frame on the post-TPA?
Well, so I mean, in general, or what should it be?
That would be.
It should be as short as possible. So the fastest
Yes.
group right now in North America is in Calgary, and their door to reperfusion is usually 20, 30 minutes.
Wow.
Yeah, so they go with they have a system where people with really big bad strokes go straight to CTA, and then they're the family's getting consent on the way to the angio suite, and then yeah, they're done. They're done. So pretty much almost all their cases are under an hour now. And so interestingly enough, this is kind of breaking news. They were piloting a study called the ESCAPE trial. I just heard about this yesterday. It was stopped early, so it was randomization, best medical therapy to endovascular therapy like this, and it was stopped early because of the overwhelming benefit of endovascular therapy. Because it's sort of been controversial but this was like a actually randomized controlled trial. And so it's, I think a lot of us didn't think it was very controversial, but now it clearly is not. We still don't know who's the best candidate, and Melinda will talk more about that.
Mm-hmm. So this graph, similar to that other graph we were looking at with IV-TPA, but looking at over time the probability of a modified Rankin score of 0 to 2, and as you can see, there's that downward slope the longer it takes for reperfusion. And this is out of the IMS-3 trial. And what's interesting about this is that for every 30 minutes, there's a 10% drop in the patient's outcome for patients with large vessel occlusions. And for every 10 minutes, there's a 3% decline. So again, that time is really of the essence that we're mobilizing and moving these patients forward quickly. So patients in general that have large vessel proximal occlusions have a 75 to a 78% chance of a modified Rankin score being above 4. And patients can have a very good outcome with rapid revascularization, as you could see with that previous graph, ideally less than 6 hours from symptom onset. The bad of it is it's about twice the hemorrhagic rate, and we still don't know exactly who will benefit and who's appropriate to move forward with endovascular treatment. So for our patient, similar workup from the previous patient that I presented, we need to find that embolic source. A majority of these embolic cases are either disease or atrial fibrillation. This was an interesting study from the Journal of American College of Cardiology, looking at patients and the link between diabetes and atrial fibrillation. And they found a prevalence in patients with diabetes to have atrial fibrillation and a significantly increased risk of stroke. And these were patients that were monitored with a Holter monitor, worn for 48 hours quarterly over 3 years. And we can consider a TEE for further workup to evaluate for a cardioembolic source. And I just want to show a couple images of some of the options for extended ambulatory cardiac rhythm monitoring. One is the Zio patch, which you can see in the picture here. It's less cumbersome than the Holter monitor with the wires and the box and everything, so it's a little bit easier to wear, but also difficult for men, especially with the chest hair. And that can be worn for 2 weeks. Based on some of the recent studies looking at the longer the time frame that you're monitoring patients, the higher yields that you have for finding atrial fibrillation, we're recommending it for 30 days. And so they can wear it for 2 cycles, so 2 weeks and then 2 weeks. But then the other device is the one that Alec was mentioning, this new Link device, and there's a little picture of it. It's very small and can be used with wireless connectivity to download the results. And for patients who live in more remote locations, there are home monitors available. And we can get those reports 30 days after they've worn that. They will give us the first report and then continue ongoing monitoring, looking for arrhythmia. And we're doing this more and more with patients. We have 2 cardiologists at Virginia Mason who insert the Link device, and so you'll probably see more of our shared patients coming back over with having had this device inserted. And I've seen a picture with it compared to a battery, like a AA battery, and it's pretty small.
Yeah, it's a little bit
smaller than that. It might even be a AAA, but yeah.
That's a good analogy.
Mm-hmm. They can leave them in, I think, 3 years, but I think
the recommendation is just to always just leave them.
one of the studies in the New England Journal of Medicine looked at 6 months of ILR monitoring with like a Link type device, and that picked up 9% of patients with atrial fibrillation versus 1% in the control group that had Holter monitoring for 24 to 48 hours. So a significant increase in detecting atrial fibrillation with that extended monitoring, which is very helpful because it does change our management in nearly all of these cases. We're talking about anticoagulation. So secondary prevention for all. As blood pressure is the highest, the leading cause of stroke, the goal for secondary prevention is a systolic blood pressure of less than 130. That came out of the SPS-3 trial, which was looking at patients with lacunar stroke. Diabetes control with a goal of the hemoglobin A1C less than 7%. And then I just had to mention the latest guidelines from the American College of Cardiology and the American Heart Association, which came out in the fall of 2013, with that recommendation for patients that have cardiovascular disease or equivalent. So patients with stroke or TIA would fit into this recommendation. They recommend a high-intensity statin for patients under the age of 75. And then for patients 75 or older, they recommend a moderate intensity statin. And that would also be same for patients with a statin intolerance. But there's also, as Dr. Takash was mentioning, the pretty frequent side effects with muscle aches, fatigue, and I have seen quite a few patients with complaints about cognitive function declining while being on the statin. So it's taking all of those things into consideration and having that discussion. And then we can't forget about sleep apnea, which doubles the risk of stroke in the same way as the same number as smoking. It's important, low threshold for sending patients for sleep studies. And I wanted to just briefly mention diet and exercise, which I think Dr. Takash covered well. These are two modifiable risk factors that are important to discuss with patients. And talking about the low-fat diet with increased fruits and vegetables. There's the DASH diet, which has been helpful for hypertension, which as a risk factor for stroke is important to discuss, and then the Mediterranean diet. And then exercise, or physical activity as I like to call it. I think some patients are intimidated by the word exercise, and so talking with them about physical activity and counting things like using stairs, parking farther away, and walking, that all counts as physical activity, even though some of us wouldn't say that's really exercise. So it's kind of interesting to think about it in those ways, but increasing physical activity. And that's all part of the latest secondary prevention guidelines as well, talking about increasing physical activity. This, I should mention, can be difficult for patients that have neurological deficits after stroke. So it's important that we're working with physical therapy, especially consulting them if they're not already involved, but helping to set up an exercise regimen for the patient that is safe and something that was doable for them. Secondary prevention for embolic. For stroke coming from the internal carotid artery, considering intervention, possibly carotid endarterectomy if the occlusion is 70 to 99%, or asymptomatic carotid stenosis greater than 80%. There are multiple calculators that are out there that are looking at risks for stroke with atrial fibrillation or risks for bleeding for patients who are on anticoagulation. The 30-day mortality, so let's talk about hemorrhagic stroke just for the final few moments here. 30-day mortality of 30 to 55% for patients with ICH. If the bleed is in the brainstem, the mortality goes up to 75%. And then 3 trials that are still pretty much ongoing. One is the MISTY trial, which is a series of clinical trials looking at trying to remove the blood clot using a thrombolytic agent or using a CT-guided endoscope. And our early results suggest that the MISTY technique reduces the rate of death and improves the patient's neurofunctioning and quality of life. There's the CLEAR IVH trial, which uses TPA to lyse intraventricular clot, and the early safety results are promising, awaiting the final results from the CLEAR 3, the phase 3 of that trial. The STITCH trial, where patients were randomly assigned to early surgery versus initial conservative treatment. Early surgery did not increase the rate of death or disability at 6 months. And there was a small but clinically significant survival advantage for patients with spontaneous superficial ICH. And one final case here. This is a 76-year-old man with a history of hypertension, peripheral vascular disease, and smoking. He presents with trouble hitting an object with the right side of his car, headache, and confusion. He's been on dual antiplatelet therapy with aspirin and Plavix for years to treat peripheral vascular disease. Here is his image, and you can see the hemorrhage right here on our non-contrast head CT. It's important that we're looking for any reversible causes of bleeding and that we're beginning reversal mechanisms right away. Our goal is to be aggressive with blood pressure management and lower the systolic blood pressure to less than 140 within the first hour to prevent any further hemorrhage. We would want to obtain a brain MRI with and without contrast to rule out any underlying mass or lesion, or to look for cerebral amyloid angiopathy. And it's possible that many of these are spontaneous lobar hemorrhages due to the dual antiplatelet use and our anticoagulation and other factors like hypertension. So in conclusion, small vessel damage from hypertension, diabetes, and smoking make up the majority of cause of ischemic and hemorrhagic strokes. IV TPA has level 1 evidence for use, level 1A evidence for use, but needs to be used quickly for benefit. The sooner we give it, the better outcomes we have for our patients, and it's important that we know how to use it and that we have mechanisms in place to proceed as quickly as possible with imaging and moving forward with TPA. Mechanical intervention is not a standard yet. Still ongoing studies. Acute management is mostly supportive for monitoring for any bleeding or swelling or any complications. Embolic strokes need evaluation for the source, as they may require surgery if it's carotid disease. We're looking at cardiac causes and the need for anticoagulation. Always remember obstructive sleep apnea. Always try to get rehab. Remember, stroke is the leading cause of long-term adult disability. So rehab is very important, and the sooner we start rehab, the better. And when in doubt, or if there's any questions on any particular cases, always call us. All right. Additional questions that you have? All right. Thank you.